to join us today. So we'll be recording and putting this on, making it available through a YouTube link once we get started here. So welcome everybody. It's great to see. It was really fun to see everyone sort of accept the meeting. It was like old home week here. I was going through withdrawal. I think we were all going through withdrawal. It was 2 months since we had our NAA meeting in January, and here we are in April. Somehow that time passed, and we've been busy doing stuff. So I'm just so grateful for folks to come back on here. I hope everyone is doing well. I hope that majority of folks have been able to get vaccinated and are on the way to some sort of normalcy here. So let me just go through what we've got planned for today. I want to just, there's some new people on the call here. I just want to do a quick sort of purpose of what we're doing here. We'll review a little bit of the NAA. We're not going to go through the detail of it, but kind of the action recommendations and how we are, thought about those and how we're moving forward on that. We're going to focus a bunch of the time on 2 of the strategic recommendations that came out of the action agenda for the bulk of the presentation. And that involves Project Unify and the work that's focused on integrated care for kids right now. And then also this privacy and consent utility service, which is really kind of a big idea that was one of the action recommendations within governance. I'm going to show you just a little bit of the work we're just launching now under the training program. It sort of supports all of this work in some ways that we're about to launch, and invite you to participate in that. And then we're going to spend some time with the partners. Each of them going to spend a little time diving a little more deeply into their solutions. Eric and Matt and Dave and other people have been involved with the Unify presentation development, but we wanted to kind of really sort of focus a little bit on that, give a little bit of a opportunity to kind of go a little bit into more of what those solutions are and how they're contributing to Unify. And then kind of next steps, how you can be involved, discussion. It's still, as always, a work in progress here. And so your participation, of course, is welcome, encouraged, and I really look forward to your thoughts as we try to go forward with this work here today. For those of you who are new, just briefly, this work is under the Stewards of Change Institute. Within the Institute, there's this thing called the National Interoperability Collaborative. And we've been working on interoperability and data sharing and system integration work for a while. So the NAA is really an outgrowth of this work. And it really fits within the National Interoperability Collaborative. I've spoken about this a bunch in the past. We had the good fortune of being able to secure funding from the Kresge Foundation a number of years ago to help us build the NIC, as we call it. And the idea of the NIC is really to cut across multiple domains, which we've identified, as human services, public health, education, public safety, emergency medical, and healthcare and IT. And the idea is to try to bring people together across these domains. And so many of the really complicated, vexing kinds of problems require the ability to interoperate not only within your domain, but across domains. And so within that context, the NAA really developed just about this time last year. No, actually, in January, February, as we were thinking about doing our event, COVID came upon us, and we switched focus to doing something virtual like the rest of the world at that time. If you remember, I've shown this Wayne Gretzky slide many times as to skating to where the puck is. When we set this idea up in last year, we were really looking at where the world would be in January of 2021, because nobody really knew what it was going to look like and how we'd be relevant, or what the work we'd be doing might be relevant at that time. Well, guess what, folks? We skated to where the puck was going. We got there, and we got to January, and then now we're in April. So it's been a really interesting year process. And so the question in my mind is, so what's next? Where is the puck headed next? And that's really a lot about what we're going to talk about, where we see it happening, at least today, and hear from you. I'd love to hear more about, the work that you may be doing that's in parallel or that's built off of this, or, sort of supportive of this work. So really over the past year, participants in the NAA really identified during that process 6 key action recommendations, and we have begun to implement a few of them. And that's really exciting. So we talked about wanting to do work that was implementable, and by hook or by crook, we have been able to sort of push that forward over the, since January, and actually a little bit before that. So, so what's next on the horizon? As you recall, formally we started the work in September and went through a whole series of meetings and work sessions and really synthesizing and iterative processes to get us to January, where we were able to actually prioritize all of this work into 6 areas. And now we're looking at what comes next and how do we implement that. So it's always, for everybody on this call who's been involved with lots of projects, it's always sort of daunting to look back and say, wow, that was a lot of work that went into that. But it's also very gratifying. And we couldn't have gotten there without you and a bunch of the other people who participated. I think in total, we had close to 200 people participate over the period of time, which is both exciting and really, again, gratifying to hear and see people's participation in the work. And so thank you for that work. Just as a reminder here, we ended up with 6 broad categories of our action recommendations. And all of you participated in some of them, some of you participated in many of them. As a way to sort of organize these things, we've talked about lived experience and bringing people in to our work with lived experience. And certainly with the new administration and the focus on equity, the tremendous focus on equity has really underscored that important approach and process. So I'm happy to say we've been able to do some of that, by no means enough of that, but we are seriously thinking about how do we do that in our work all throughout. And we see that, with foundations and organizations really calling this question to the table of how do we really address equity in people who are part of the process here. Data sharing and integration, obviously, sort of percolated up as a significant opportunity and a real area to focus on. Governance writ large is important, and then there are specific pieces of governance, and we chose one of those. The consent utility service is, in fact, the way I think about it in terms of a governance process. How do you do consent within the governance structure? Care coordination, how do we bring all these things together to bear on the actual service providers and people and clients and patients who are receiving services? Housing, which before we got into this work was always important, but never really rose to the level of primacy that it really did here. And I'm really glad for the focus on housing. And it's one of those things, once you start to focus on it, it becomes evident how broad and how important it is out there. And so there was a lot of work in terms of housing. Again, even in the new, the new budget, housing has taken a tremendous focus of the new investments. And then, of course, civil justice. And that's an area that is, I think, generally outside of the world of social determinants or social factors. And the work we were able to do with Pew Charitable Trust and really look at civil justice system, the interconnection with all the stuff we've been doing, all the stuff you do all the time, is a critical piece to call out. And so, I think that from the enormous amount of work, we were able to sort of narrow this down into these areas. There's a link, and we'll post this, and you probably all already have the information. It's on the hub. But we put the action recommendations, the summary, kind of a paragraph of each of these, and then the actual Google worksheets on this link. So you can actually dive into it. And I've been excited to be able to share that with people and organizations who have interested in it. I'll talk a little bit more about that. One of the partners in that is the Robert Wood Johnson Foundation. They're embarking on a new initiative that they've asked us to participate in terms of the next strategic effort. And so we've been able to share, because they were looking at, well, what are the major problems out there that are inhibiting interoperability, information sharing? parenthetically, it's great to have a giant foundation think about and actually start to engage with these topics, some of the technical topics and some of the interoperability topics, which I haven't really seen that in the past. And so that's been very encouraging. And to be able to share the breadth and the depth of knowledge that's really come from this group has been tremendous. Sort of expedited their process. And I think we'll embed it into some of the recommendations that they're coming out with as early as the summer, and new ways where they're going to be making investments. So we're out there waving the flag around all of these topics, and in particular the opportunities to really make substantive change. So I encourage you, if you haven't been there, take a look at it. They're not going away. So out of the 6 recommendations, 2 really have really emerged, as I said earlier. One is Project Unify continues to move forward. There's been a variety of people, a number of people who, both from the vendor community and from the federal community and others, who have been plugging away week to week. We've been meeting and working on a variety of things, some of which you'll see today. And that is closely connected to integrated care for kids, and particularly in New Jersey, where Dr. McCoy has been leading the charge there. And we'll hear a little bit more on an update from her and the Unify folks. And as I said, the other strategic focus area is this privacy and consent utility service. So how do we think about consent more than just HIPAA consent and healthcare consent, but reaching across to education, behavioral health, and advanced directives? Is there a consent utility? And as you recall, one of the things that we talked about a lot and was really primal for me was, is there something that could actually have a substantive structural impact on the work we're doing? And it feels like this is one of those things that could actually do it. Because as we've been starting to scratch at that, we're finding, of course, a whole lot of fragmentation and a real desire and need for doing more work to create some kind of standardized, replicable model. So those are the 2 areas that I can say we have been continuing to work on since January. We'll share some of that work with you today. And what I'd like to do is ask Brian to do a quick review of kind of Unify vision, and then we'll dive into that into a little bit more depth. So Brian, I think you should be on board there.
Thank you, Daniel.
You bet.
Indeed, the Project Unify vision and approach is to try to tackle some of these challenges to interoperability through working groups that try to come up with best practices for how to resolve these challenges based on standards, open APIs, open data, open source technology, and then to prove the concepts through various demonstrations of how, based on these open technologies and standards, we can create replicable interoperability and information sharing between healthcare, education, human services, housing, the courts, child welfare, etc. Next slide. And we are doing so with an august team of core participants who are each subject matter experts within their own realms, whether they're healthcare, Medicaid, child welfare, et cetera. I'll let you read the left-hand side of the slide. And they have been, we have had tremendous contributions from all of the folks on the right-hand side of the slide in the various working groups. But we want to provide special thanks to those organizations that have invested their time and resources and products and modifications to their products simply to provide these proof of concepts as part of the demos. And that includes ServingLink, Open City Labs, MightAttack, and the Interoperability Institute. So kudos and thank you to each. Next slide. As part of our work, not only are we attempting to demonstrate the ability to exchange data based on these domain-specific standards, but also to develop the specific person matching mechanisms that we need to be able to kind of solve the problem of determining, is this the same Susan Smith in the healthcare system that we have in the human services system, that we may have in the housing system? so that we can create 360-degree views of information associated with individuals. And then because we've got information that's being pulled together or exchanged between multiple different domains, how do we map between the different data representations within these different domains? How do we access this data through existing and or new reusable APIs? And do so in a way that is based on the best practices of security protocols and privacy and consent mechanisms available out there. In the process, our intent is to document these best practices in blueprints, or if you will, implementers agreements that specify what open source technology, what open APIs, what open data models, what open protocols and standards we're using to accelerate the use of, to accelerate interoperability and industry adoption of these technologies. Next slide. Now we're taking an integrated approach based on really a person-centric, family-centric, community-centric model that highlights the multiple different domains of information, the multiple different participants in the life of the individual, family, and the community. And as a consequence, the multiple different systems of truth and the data that lives in those systems of truth that we then need to provide interoperability and integration across for the benefit of the well-being and health of the participants in that family or community. Next slide. To, to, to drive our work, we have been using a group of personas, a group of hypothetical individual definitions and information about their lives, as sometimes as brutal as those fictional lives have been, in order to be able to tease out the challenges that families and individuals face in gaining equitable healthcare, equitable human services in order to improve their lot in life. And so we have the Thompson family and their many different tales of woe to help inform inform the technical work that we're attempting to do to break down the interfaces between various silos of domain-specific information. Next slide. And it is being driven by the specific requirements for the CMMI Integrated Care for Kids program, of which the New Jersey VNA was one of the awardees. And do we have Dr. McCoy with us? It would be great if she could give us an overview of the Integrated Care for Kids program.
Sure. Yeah, I'm here, Brian. So,
Hi, Christine.
so yeah, I mean, I have a feeling probably most of you on this call have heard about the Integrated Care for Kids project before. And so I will give a 90-second overview and then try to give kind of a big picture update of what's happening with integrated care for kids. So the 90 seconds is that, you know, this is the first attempt by CMS through the Center for Medicare and Medicaid Innovation to put a Medicaid-sponsored program in place in the pediatric realm. They've done a lot of work in the adult realm around high cost, high utilization adults, and whether using alternative payment models and methods like ACOs, et cetera, can really help to change the course of people's lives, not just as consumers of healthcare, but also the quality of life for adults. And they really hadn't done that in kids. And so this is really that first attempt in kids. There are 8 awards around the country, 2 in Illinois. and the other 6 across the country, ranging from Oregon to several along the eastern seaboard, being Connecticut, New York, New Jersey, and North Carolina. And then the 2 in Illinois and Ohio being kind of the central part of the country where this is happening. And I think what's super important about integrated care for kids is that the #1 outcome that we are supposed to be preventing, negative outcome, is placement outside of the home. Now, that might be a medical placement outside of the home. That might be a long-term hospitalization, psychiatric, substance abuse, or physical health related. There are nursing homes for children, for example. But for the most part, the vast majority of placements outside of the home for kids have more to do with the child welfare system and the juvenile justice system rather than healthcare itself. And so while this is coming out of healthcare, it really is by definition a cross-domain project. And as you can see from the bullets in front of you, those are some of the key domains that CMMI has specified. Interestingly, though, when this was developed, there was not probably enough intergovernmental discussion about this program. And so they launched it in hopes essentially that the 8 groups around the country that they funded would help to sort of crack this nut open for them. And the reality is that this is really circling back to the federal government at this point in time. And I just wanted to explain that sort of process to everyone, because I think some of you are certainly very interested in this policy at the federal level, may have influence on this policy at the federal level. And so to understand what's happened with these integrated care for kids projects is, from the standpoint of the 8 projects, we always knew that we needed to try to get our hands, to build relationships across these domains at the local level for the kids for whom we would be doing an intervention. And so all of us set about diligently trying to build those relationships and put data use agreements in place. Very much stymied by the COVID epidemic. People were busy, the methods of communication, et cetera. Obviously, everything changed a year ago this time. And so it was hard to do this, but everybody was working on it. And the focus really was on, we obviously, if we're doing an intervention for these kids, we need to really be working with their schools, working with the child welfare system, working, if we can, with juvenile justice, and making these connections and sharing as much data electronically as possible, because the electronic interoperability was explicitly included in the Inc. model. Then we all got thrown kind of a big monkey wrench by CMS in the fall, where they suddenly announced to all 8 of us that they expected us to provide to them being CMS, identified child level data from each one of these sectors. So not just for the intervention kids, but for all, quote, attributed children. So in our case in New Jersey, that's 140,000 kids. New York has a similar size group of kids. Several of the other projects are quite large as well too. And so there was this sort of expectation from CMS that we could magically have identified level data on child welfare on 140,000 kids, the vast majority of whom we were really doing nothing for. And so all of us who had been working, trying to come up with data use agreements around the kids for whom we were going to do an intervention, suddenly were faced with going back to these agencies and saying, oh no, now CMS wants us to have this data on every single Medicaid enrolled, child and young adult in this geography. And needless to say, the states told us, forget it, you're crazy, go away. And so the bottom line is, there's a big policy agenda here on the part of CMS to really understand these intersection of these social determinants of health. And I think we all understand, and we all are supportive of that. And yet at the same time, the world is not ready to give up this data, this identified child level data, in order to kind of do this sort of massive data analysis of the intersection of these different sectors. And so I think there's going to be a very, very interesting discussion occurring between CMS, the other parts of HHS, who were also not interested in giving up this data. The Administration for Children and Families, the Children's Bureau, the Maternal Child Health Bureau, all of the programs funded out of Title V, et cetera, much less education and agriculture, which is funding WIC and SNAP, et cetera. And we'll see kind of where this all goes over the coming months. So I think I wouldn't say it's inadvertent, but it was unexpected from the standpoint of the awardees of these cooperative agreements, that this much, much larger discussion around looking at this, the intersection of these sectors at a very specific child level, is going to be looked at more broadly. So we're in a little bit of, I wouldn't say a pause, but it has kind of brought us all up short, and we haven't done as much work as we might have done otherwise, because we don't know whether we're asking for every child's data or just the data on the children for whom we will be providing a particular intervention. So a big challenge ahead of us. On the interesting side, to go back to Daniel's slide about skating to where the puck is going to be, I did want to point out that on January 7th, CMS did put out a very explicit statement about social determinants of health and Medicaid. And, so I think, that's an example of where this NAA process, was if not ahead of the curve, certainly in parallel with the curve in terms of where CMS was going. And I think that's really critical in the context of children's health, because a well child check in the children's system in Medicaid is this something called the EPSDT, or Early Prevention, Screening, Diagnosis, and Treatment visit. And the concept is that anything that's unearthed in the process of that visit, following the standards called Bright Futures, which include asking about food insecurity, housing insecurity, behavioral health, all of these issues that we're talking about, that Medicaid is supposed to take a role in solving those problems. And so, it really does potentially unlock a source of funding, towards working on these social determinants of health issues in these other sectors that has not necessarily been tapped into in a lot of depth so far. So I think I will leave it there, but I, just wanted to let everybody understand kind of the big picture of where we were at in terms of these discussions. And in the meantime, very excited that we're working, with Project Unify on, some of the specifics, and then the consent discussion that we're going to dive into in a minute.
Thanks, Christine.
Thank you, Dr. McCoy. Next slide.
For you.
So we've made, within Project Unify, we've been making significant progress since last year. We continue to have weekly planning meetings, technical working groups, and various proof of concept demonstration development meetings. And with a specific focus recently on user story driven data sharing specifications to try to address, which social determinants of health information needs to be exchanged, as well as which person demographic information needs to be exchanged between various siloed domains. How to deal with person matching between various domains. We know that patient matching is already challenging enough just within the context of the healthcare world. And it becomes even more challenging when you start going across these various domains between which we're attempting to exchange information. And then, of course, if you're going to exchange information, much of which is protected by various laws, we need to make sure that we have appropriate consent for sharing that information and for it being read and or acted upon by various roles and or individuals. So we've got a pair of consent working groups now that are working. One on governance and steering requirements, and another on consent technology. In the process, these working groups are generating blueprints that we are attempting to demonstrate the effectiveness of those implemented agreements, those blueprints. And we've got 3 technical demonstrations in the can at this point. There was the homeless social determinants of health demonstration from November 6th of last year. A prepare to electronic health record system to community-based referral organization data flow from January 25th of this year as part of the NAA symposium. And we are just finishing up a homeless rehab COVID data flow. And the next few slides, I'll get into the gory details very briefly of those 3. Next slide. So the homeless SDOH data flow involved a shelter management app working with a HUD standard HMIS homeless management information system that had one of our personas, John Thompson, checking into a homeless shelter, and in the process had checked into the homeless shelter often enough that he was deemed to be chronically homeless. There's a very specific algorithm for determining that, as well as qualifying for being considered having housing instability, homelessness, which now has a specific code for it in SNOMED. And the existence of these codes within the homeless management information system enabled the human services case management system to subscribe to and discover that John was perhaps in need of some support services. Based on a social worker using this human services case management system, then hypothetically interviewing John to determine his interest and eligibility, the case management system was able to generate both rental assistance applications and SNAP food assistance applications, which were could be sent as referrals using FHIR or 360X over direct, secure messaging, or fax, or printed out and carried over. This was exciting simply because it provided our first experience using FHIR, specifically the FHIR subscription mechanism, for exchanging information between 2 different domains, the housing domain, the homeless management information system domain, and a human services case management domain. Next slide.
But let me just pause for a second, see if
Sure.
Eric or Matt or Dave want to comment, or if there's any questions from participants. So now would be a great time if you wanted to elaborate. We're going to get into some more, a little bit more of the details, but just wanted to open it up to particularly Eric on the homeless piece.
Good call. And now Eric's on the spot.
Okay, well, should have given him a heads up on that one. I'm not sure if he's triple muted or something like that. Okay, well, we'll come back to this.
Sorry, Daniel. I was triple muted. They're all unmuted now. I just wanted to point out, we're just using HUD standards. HUD doesn't sanction this work. So the Petone app, HS Link aren't, affiliated with HUD in any way. But we do have videos of each of these demos linked off the Unify landing page. So if you want to see like the actual original for these, they're all online.
And I'll just also clarify about 360X. We haven't implemented that yet. Right now, I am helping to write the social determinants of health implementation guide for EHR to human service provider referrals. And that's kind of in the earlier stages of the process, but that's definitely something that's on the roadmap of Project Unify. And so I just wanted to kind of update that. So thanks.
Sorry to oversell.
Fine. If anybody is interested in learning more about being able to send, from one EHR to another or another system, I'm happy to talk offline about those things.
So Elaine, a quick question from Elena here. Does the demo envision that the person who is homeless has access as well at this point in the demo?
And Matt, I think that's yours to handle.
Has access to what? I'm not sure I understand.
Care 360, maybe?
Do you mean, do they have access to the system? Can they help themselves access services? Is that what you mean?
Yeah, no, sorry. I was just, if a human services case manager has access to the information, are you all thinking about at some point allowing the individual, him or herself or themselves to?
Yeah, so the particular demo that Brian's talking about was of Navigator, which is for the case manager that's helping the client. But we also have a tool called Care 360, which is for the individual to help themselves and their family access programs and services through a similar interface.
Thank you.
Yeah, I want to point out just that I think, Brian, you said this earlier, that we're trying to take a discrete piece of a problem and show that you can move data between these different things using either existing standards, interoperability standards, existing codes, and existing technologies to actually show how it's done, show that it can be done. Again, thinking about the Thompson family, thinking about Inc., thinking about New Jersey and New York, and that's part of that. That's the foundation. Okay, Brian.
So the second demonstration we did, which was January 25th, was here we were creating a prepare survey app based on a technology called Flutter that I think Dave is going to talk about a little later, as well as the fire questionnaire and questionnaire response resources to put in the hands of the patient, the end user, a mechanism for indicating whether or not they do have a specific need, such as a need for food or clothing, utilities, housing, etc. And in the process, in this particular demonstration, Sarah Thompson, one of our personas, had indicated that she had food insecurity, and I think it was either childcare, housing insecurity, and that information was stored in electronic health record system in the form of a happy fire server for anybody that cares, in the form of both an observation based on a link code, as well as a health concern condition based on a SNOMED code. These are codes that were defined originally by the Gravity Project within HL7 Fire Accelerator as a fire accelerator program. In turn, those conditions were subscribed to by the Human Services Case Management System using a fire subscription or polling service. I think in this particular case, it was implemented as polling. And in turn, I think in the demonstration, we demonstrated the ability to generate and pre-populate a WIC application for Sarah Thompson. But it could just as easily have handled childcare or housing or just about any other service that was out there. And again, I think in that particular case, we were printing the document out or faxing it rather than sending it over 360X. I'm just not overselling you now, Matt. Do you gentlemen have anything else you want to add in about this? Including Dave. Okay, next.
Well, I just wanted to say, like, well, I work in technology, and technologists sometimes have this tendency to think of the most high-tech system way of solving a problem. Sometimes it's the simple approaches that are what we need to do to get things done sooner. So I guess I just wanted to underline that as a way of thinking about these things.
Indeed, Matt. Thanks.
So the current demonstration that we're in the process of editing the video for it for release shortly is for a homeless rehab COVID example. In this hypothetical scenario, Sarah Thompson, who in our Stephen King-like user stories has become has a substance use disorder due to a warehouse accident that got her hooked on opioids, and has unfortunately crashed her car and is arrested. Yet the judge takes her kids away from her, saying you can't be an effective mother if you're having an opioid addiction at the moment. So it gives the kids to her mother to take care of. And she loses her job because she was working now as a grocery delivery person and no longer having a car or usable license. She can't do that work. She loses her apartment. So the judge says, look, to get your home back again, to get your life back again, really, and get your kids back, you need to get yourself clean, work with some social workers as well to get the necessary services that you need to get back into a home, to get the food and other assistance you need to be able to take care of your kids. And so we're going to refer you to a homeless rehab facility program. Now, in order to get into the homeless rehab facility, Sarah is asked to take a survey. It's the standard one that we all get when we attempt to go to the doctors. Have you been diagnosed with COVID in the last 2 weeks? Have you hung out with anybody that was diagnosed with COVID in the last 2 weeks? Or have you had any of this litany of respiratory symptoms that might suggest you have COVID? And Sarah downloads this survey from her doctor's office, takes the survey. It indicates to her clinical record that yes, she has suspected COVID, to hopefully trigger her primary care physician to do a telehealth visit with her, maybe send her in for testing to determine if she really is. However, Sarah has exercised her 42 CFR Part 2 rights and said, I don't want anybody to know that I have an opioid addiction. I'm really embarrassed that I've fallen into this trap here. And, so I don't even want my doctor to know that I have this. Well, this puts the rehab facility in some difficulty because they may not be able to, depending on what kind of a facility they are and how well integrated they are with the healthcare system, they may not be able to tell the primary care physician or out Sarah as having a substance use disorder. So we've created a community infectious disease alert service, which could be used for homeless shelters, by rehab centers, by assisted living condominium complexes, schools, corporate campuses, bingo halls, with appropriate consent, to sort of allow those communities to subscribe to, whether or not somebody has come down with COVID or just about any other infectious disease. And that Community Infectious Disease Alert Service in turn subscribes for all of that pool of patients to their information from the EHR. And if one of the subscribed patient IDs is indicated as being diagnosed with or having a health concern of COVID, then that information is shared, again, I emphasize, based on consent, with the appropriate community so that they can do the right thing. In this particular case, Sarah will be accepted as a rehab client, but put into one of their isolation rooms so that she can go through rehab as well as recover from COVID in the process. Comments from participants? Okay, next, I think we are on to consent. Daniel,
Yep.
back to you.
Yeah, let me speed it up here a little bit. So the other big deal, again, the work that Brian just described and others, that's kind of in process. A lot of work going on in there. Much more detail on the hub about it. Again, it's not a production solution. It's a demonstration of what's possible, and to expand our minds about those possibilities. And how do we then learn from that? And that's what we want to make available to everyone. That these are ways to do it. Brian referred to the blueprint before. In much the same way, we're thinking about this, as for those of you who participated in NAA, one of the things really came up with this idea of consent and governance, and that really percolated to the surface as something that's really super important in order to enable interoperability and information sharing. And we know now, nothing surprising on this, it's critical for realizing coordinated care. If you can't get those consents easily, at all, no less easily, we're not going to be able to get to the clinical solution. There appear to be multiple overlapping consent requirements. Well, there are multiple overlapping consent requirements that require different levels of specification. There are the current situation is there's extensive duplication and reinvention. There's no standards or guide or roadmap. Surprise, right? We find that again as we've been starting to look out, talking to folks in different communities. Everybody's solving their problem, but we haven't seen a collaborative yet, a collaborative approach to actually addressing the issue in a way that could be replicated. So there's no national model now. We've talked a little bit about consent to share, which came out of SAMHSA and has been led by Ken Salyards, who's now at ACF. But that's very narrowly focused. Is there a way to actually create something that could be adapted and customized and replicated in communities across the country? So I think that what we've come to realize, even at the surface here, is like there's a lot of fragmentation. There's a lot of good work going on. There's been no collection of this, at least to have a snapshot. So we are teeing up this scan of sort of leading and promising consent models, approaches, standards, as we bring together people. There's been a number of people who stepped forward wanting to participate in this work group. We'll talk about that just briefly at the end. That is a place, if you have interest and concern, it's got some momentum. We've got representation from New York, from New Jersey, San Diego, a number of other places, and a lot of subject matter expertise around this area. So stay tuned for this. We'll be ramping this up, and I think it'll be hugely important, both for education, as we try to integrate education, behavioral health, advanced directives, as well as physical, behavioral, mental health care services. Jump in if anyone has a thought. There's a long conversation coming out here. So
Daniel,
yeah.
if I could ask you a question, I'm very excited about this last thing.
Great.
There is emerging work being done in a number of states, as you know, I think, to have interoperable networks established kind of as public utilities, quasi-public-private efforts to try to solve the problem of Dave has Aunt Bertha installed in his hospital, and Joe has Unite Us installed in their town, and others have their own homegrown versions. And so we're seeing states, in Colorado, this is certainly happening, the states trying to say, come, let us reason together and try to use the kind of standards that you guys are developing to. Is it your thought, is the architectural thought that this particular service that you're describing would be a utility in that kind of model, and therefore would be something like, I think CDC just put $250 million on the street for building these kinds of networks. Is that what you're thinking?
Yeah, I would say precisely. It's, some things need to be obviously customized. Everything needs to be customized to individual jurisdiction, but do we need, is there a utility or that can actually address these issues? But that everybody doesn't have to recreate from scratch. What are the practices out there? The state laws are all unique, there's federal baseline law, but many states have different laws and different requirements, as we know. So it's got to be flexible enough, but we shouldn't have to create that. Every jurisdiction should not have to create that solution. And it should roll up to a region, it should roll up to a national. And the same way, there's in fact conversation has been, bottom up, top down, or middle out. So that's precisely it, David. It's an idea that I think warrants some serious consideration. And certainly there are people thinking about this. And it's great to know about the CDC part as well, because it will take more funding than we certainly have at this point in time to keep that ball rolling. And so, any commentary or any involvement you want to contribute to that thinking would be certainly welcome.
I think you read one of my slides in my presentation later today, because I'm going to touch on just that issue. So.
Well, everybody's going to start to do their own thing if you don't fix it for them. And there's nothing bottom up of value here. It's kind of having a technical solution that then the rules can be different. Right. The business rules can be different, but the technology ought to be able to be the same. We're dealing with this exact same problem everywhere.
Yeah, exactly. So let me, we're going to get into a little bit more detail on that. I wanted to spend the next little while here for each of our partners to go a little bit more into detail on how their contribution to the solution fits and how it might be of interest in a broader context there. So Eric, you're up first here. Do you want me to drive your slides or I don't know?
Sure, okay, that sounds good. Okay, sorry for the massive font, but this is a really important point here. Community information exchange, data exchange, whatever you want to call it, is typically offered by large proprietary systems. And it's really important for the accountability, the ability to have transparency in the processes that are happening with community data exchanges, for the code to be open source. And so there's a huge proliferation of community data exchanges already occurring across the nation, and communities really need to bear in mind that they may be getting locked into something that will be very hard to extricate themselves from if they don't have an open source foundation for their exchange. At some level, the community needs to have a license to continue to maintain their community exchange aside from the existing vendor they've chosen. So I think it's really important that the font, the typeface size is so massive, because I don't know if this point is really getting across as people are signing massive contracts with massive vendors. And the typical pattern with this is that people reprocure every 5 years for new software. But with a community information exchange, that would be hard to do if you're building a lot of homegrown community apps around that exchange, or layering on integrations that are hard to redo over time. And so HSLink, which is one of the partners of Project Unify, has an open source community data exchange that everything is transparent on how data is manipulated within that community information exchange. That has benefits for security, for auditability, for not only equitable processes, but for just accuracy or doing things in the way that is mandated by the federal government. So I just really want to emphasize that the importance of open source for community data exchange, not just having a community exchange of some sort. Could you flip to the next slide, Daniel, please? By the way, my name is Eric Yan. I'm the CTO of HSLink. So obviously I have a bias in my opinions, but I mean, the main point is whatever you do, I would go with open source for your community exchange. The apps that surround your community exchange, that can be open or closed source. The key there is that they implement open standards for the communication with the community information exchange. Because of this, we're a part of Project Unify. We consider it a great environment for finding other apps and coordinating with other apps that play nice together. In other words, it shouldn't be the communities, each community in the United States tasked to get these vendors to work together using open standards. And Project Unify is a great forum for us to work with other great companies such as Open City Labs and MightAttack to develop solutions that work out of the box for communities, to do the advanced standards interoperability works so that each community doesn't have to separately pay for things to just work together. And so we really appreciate this forum of Project Unify to both discuss. We argue a lot about how far along the fire path should we go, or how far along this path should we go. We argue a lot, but in the end, we ultimately decide upon standards or make recommendations for future standards and implement and make things work for our demonstrations that we do on a bi-monthly basis. Could you advance to the next slide, Daniel? So more about HSLink. It's an open source exchange, as I've mentioned already. By the way, we have our chair, Carl Trelevin, our president, Norris Brown, and one of our senior engineers, Sandeep Dolia, on the call today. Just wanted to point that out. The idea here is it doesn't have to be apps from your community that integrate with the community exchange, the open source one, be it HSLink or whatever you may find. But it could be a legacy system already, and as long as it can communicate in the open protocols, it should be fine. One of the could you advance to the next slide, Daniel? One of the key things that's going on with the community data exchange that's great is that the community in the upper part of this graphic, we'll animate it soon, but there's a large dome on each image. That's the community data exchange. So we've got a scenario with something like HSLink or something without it. With the community data exchange, the data at the community level that's data centric and centrally stored in the large dome on the image in each of the quadrants shows how much data the community possesses. So with an effective community data exchange, the apps are only checking out the data that they need at for the transaction at hand. And then it's checked back in with the changes or whatever to the community data exchange. Now these apps can also interoperate directly with each other without working with the community data exchange, but then you lose some of the transparency and the community loses its ability to have all the data on tap within its purview. Without an effective community data exchange, this is the lower half of the slide divided by the horizontal line. You can see that when one of the apps is removed, all that data is lost unless it's migrated to a new version of itself. And usually because they're proprietary, that can't be done fully. You'll lose a lot of your data. If there are any standards that can be exported to, you may be able to save that if it's translated, correctly, but a lot of data is lost in migrations. These happen every 5 years with reprocurement typically. And it's horrible for a community. The community, at any one point in time, the community has no data because they're not interoperating with an exchange. All the data is within the walled garden of each vendor proprietary system. So you can see how the data-centric model, as implemented by the community data exchange, puts the data in the hands of the community at all times. And the apps, it turns it on its head. The apps aren't in control of the community's data resource. They're actually just checking it out like books in a library. And so we just think that this data-centric model, and I didn't coin that term. That's been there's many others who have expounded on data-centric if you Google that. But it's a great concept that really is exploited by community data exchanges. Next slide, please. Daniel.
So Eric, we were running a little late here, so we're kind of curtailing a little bit. So I just want to.
Okay. I'll speed it up.
No,
here's the links for our code, our APIs. So just want to be all transparent about that. Next slide, please. Many different apps already exist for the HSLink Community Information Exchange. We've got a newly released HMIS. We've got an administrative app. We have coordinated housing entry, but that can be also used for any kind of resource matching. We can modify the workflows for things other than housing. Next slide, please, Daniel. So there's a big data warehouse where all the data gets read-only synced to, and then you can choose your analytics tool to have access controlled analytics. So depending on the user's role, they can see what they need to, and you pick your favorite tool. Apache Zeppelin's the only one of those that's open source fully. Our Shiny, I think, has some open source parts as well. Last slide. We have complex project grouping and data sharing, which involves groups, subgroups, global groups. You can actually overlap the groupings. So you could have a regional initiative that involves children only overlapping with many communities. We want to implement with consent to share interoperability. So our client consent controls that exist already could then interoperate with national efforts and just work transparently through the existing APIs. We have an open source master person index at the middle. There's a golden view, or AKA 360 view. We use usage-based pricing for the implementation that HSLink hosts of the open source code, as opposed to per seat licensing. And the resource matching can be customizable. I think the last slide is our contact information. Just shoot me an email if you want to learn more. We really need contributors as well. So if a community wants to build apps or add to the code base or add features that they like, when you do that, you have a perpetual license to that code, and it will work on the software. So it's not like you're assisting the vendor to build up their proprietary product base. So it's very important to work with an open source one. So thank you all for your time. I'll pass it back to Daniel.
Thank you so much, and thanks, Eric, for kind of giving an overview. A lot of this stuff is on the hub, and of course, you can find it on ServingLink's site. And I want to thank you personally for all of the work and effort that you've really put into helping support this work in a really open source way. So with that, I want to introduce Matt Bishop from Open City Labs. Matt, take it away. I know we've shortened our time a little bit, so we stay within the time here. So
Sure.
We'll keep you posted on that.
Sure. Well, thanks for having me. So I'm the founder and CEO of Open City Labs, and I started the company because I wanted to empower providers. Our mission is to enable you to provide the best care by making healthcare and human services and government benefits, connecting all these actors making their services individually personalized, universally accessible, and one click away. And in order to achieve this, we need to make these programs more accessible. We need to streamline eligibility, screening, referral, and enrollments in these programs and services. And in order to do that, we need interoperability. We need to be able to use data in one system to streamline the process of accessing these programs and services in the other. And that's fundamental to how we approach our technology, and also fundamental to how we're trying to make interoperability affordable by embracing open protocols, which I'll talk about later. So we have a set of integrated products. So Care 360 is for the person or the patient to set goals, access the one-stop shop. Navigator 360 is for the case manager or care coordinator who's referring, screening for eligibility for things like SNAP, and automating the application forms and getting a 360 view. And then we also, Agency 360 is about the organizations that are administering the program. That maybe they're managing a set of providers, they're reviewing applicants to the program, right? And we believe that that needs to be kind of integrated into the component of the actual providers that are being hired to implement the program. And then analytics. Could we go to the next slide, please?
Yep.
So OpenCity Labs, so we provide a single point of sign up and referral for healthcare, social services, and government benefits. So we've aggregated information about over 300 government programs. And again, like I said, that data can be reused to, like as seen in our WIC demo, to autofill application forms for things like WIC and cut the time people spend making referrals in half. Next slide.
And I'll just add that's built into the demo, is being able to move that data around.
Exactly.
You're going to show that.
So the Navigator and Care Portal are the staff and patient portals for getting recommendations based on goals and barriers, eligibility, applying, and then referral. Next slide, please. And Agency 360, so currently, if you get a grant from a government program, right, and you're administering that grant, and then there's some kind of update in the eligibility requirements, for example, right, your organization might get a PDF or an email, and that case manager can't keep in their mind those program changes and then see, their 50 clients and apply that from their mind to each client. It's just infeasible. And so by having one system where that can be updated, and then all the organizations that are using Navigator to administer that program can then automatically see that update and the questions change for eligibility, et cetera. That's one of the main purposes of Agency 360. Next slide, please. So one of the really important parts of creating this interoperability is to be able to pull in data from multiple sources so that you can provide this 360-degree view of the client or person. And this, we take a highly customized approach. So we intentionally set out actually modeling an organization's data, aligning it with standards and generating interfaces that are custom built to your, let's say, human service domain, or then you can, so these kind of longitudinal records could be many different things depending on your domain. Next slide, please. So the problem that we're trying to address, because we don't have interoperability in our referral systems, referrals are mostly made on the phone. And that's fundamentally because if you make a referral in this system, whether you're talking about two different EHRs or you're talking about a community-based referral organization like, NAPA and Bertha, et cetera, et cetera, et cetera, fundamentally, the model is broken because unless both organizations are using the same system, the loop does not get closed. And that means that people don't know if patients are receiving services, and that means that we don't know if we're having an impact. So next slide, please. And next slide. So fundamentally, it's because the business model, how businesses charge for integration is totally broken. So if you have a referral tool in the middle and it's integrating with an EHR and you want to pull the data from the EHR and you want it to go directly to a case management system so that you're not updating your referral tool and the case management system, the EHR is going to charge you $10,000 to send any data, and the case management system is going to charge you $10,000. So if you have 50 referral partners and you want to have interoperability with all 50 of them, you're paying $1 million just in interoperability costs alone because of the nature of the system. So could you click ahead? So we are working within standards making organizations. There's one organization called Direct Trust, which the way it works is it was started from a grant from ONC. It's now its own nonprofit governance. And just about every electronic health record currently is aggregating data. Primarily, it's been for healthcare providers where they, list what services they have. And they can then send HIPAA compliant secure messages that are essentially programmable. You can think about like a programmable secure email. And all that data, all the Epic's customers and NextGen's customers, all the hospital systems, all that data is updated to the same national directory. So you can send messages using this protocol. And we believe that this is a model where, we can all be contributing to the same national directory. And we are trying to advance standards that allow, so to David's point earlier, to allow if, Aunt Bertha or Unite Us want to join the national directory and add all the community resources to that national directory, that's what Open City Labs is planning on doing with our own customers. So we're trying to advance these standards. So why is this interoperability all important? How does this affect people's real life? So case managers, in order to discover information about a client, if the data is not standardized, search is going to be very difficult. If you want to automate workflows, if you want to be able to reuse data, it needs to be standardized. If you want a shared understanding to improve care management for your clients, you need standardized data. And finally, if we want to talk about population equity, whether we're talking about racial health outcomes or outcomes that cut across the social determinants of health, if we want to even really understand and quantify the inequities that cut across the social determinants of health, we need to have a common understanding of what that looks like. And that means having common definitions that tell us where we are so we can set goals and try to move the ball down the court, so to speak. Next slide, please. So yeah, I'd love to talk to you more about some of these things and get you involved with any kind of open standards making efforts. And yeah, thanks a lot.
Thank you, Matt. Again, an integral part of creating the demos and thinking it through technically and from policy perspective. And so we appreciate that effort and hope you appreciate it as well. I'm going to ask Dave Walsh, CEO of MitAttack and a long-term partner of many of us here, to say a few words. As you know, Dave has been around the Medicaid world for a long time. And so a lot to say, but Dave, if you could also just kind of shorten it up a little bit, just so we have a couple minutes at the very end. We don't want to ask people to stay too long here. So away you go. Oh no, do you have the double or the triple muting?
Yeah, so this really targets what David was saying a few minutes ago. And the goal of this is really to encourage people on this call to see the value in participating on the UX working group, the user experience working group. So the world that we see of the future is very much like what we're seeing in fire for the healthcare arena, and similar things for human services, and then devices of many sorts that people can use to be able to access that information. So our goal really was to make it easier to build applications for health and the social determinants of health. So we're not saying, hey, buy our product. What we're saying is, here is an open source framework from which you can build products as you move forward. We also want to build testing tools. I think that's a big issue that we're all going to be facing, and something that really helps promote interoperability and security. So next, Daniel. So if you look at the arena of what tools are out there to be able to achieve something like this, there is one, the blue line that goes from the bottom left to the upper right, that was designed by Google and is now being adopted by Microsoft and Amazon and others, to be able to develop applications that in fact can run on smartphones, either Android or iPhones, can run on desktops, can run in the browser. So kind of your write once, run everywhere sort of an approach. Next slide. So real quick, what we're going to be looking at in the UX working group is a platform that already understands how to access every version of Fire and the majority of the Fire servers that are out there. So it makes it very easy if you're writing an application to be able to access that Fire data and soon the social determinants of health data. So you don't have to figure that out. You don't have to go in and understand how SMART works for security and so forth. That's all kind of in this free open source framework that we're going to be focusing on. And in the interest of going quickly, what we have done is built that framework. It's working now, and anybody's welcome to go use it. And then we looked at what is one application that we can implement to show the value of the framework going forward. And what we focused on was the Gravity Prepare application. And we built that in a manner that you can take that application and tune it to meet your needs. Now, one of the things that we have realized recently is that although what we did was very much aligned with Prepare and the National Association of Community Health Centers and so forth, what we need to really focus on now, and are beginning to in earnest focus on this, is how do we make these questionnaires usable by people? How do we make sure that they can navigate through the whole questionnaire? We all know that questionnaires are tough for people to go through. They get bored, they get confused, and so forth. So our focus now is, how do we make that more accessible? And the other part that I mentioned a while ago, about using it on different devices. I know my PCP sends me an email and I can open it up in a browser and start filling out the questionnaire. If I haven't completed it, when I go in there, they hand me a tablet to finish up the questionnaire. So this technological approach will let you do that. And it is not just for Gravity, it's for any questionnaires that you want to implement. So can you go to the next one, Daniel? trying to be quick here. And that is a recap of the different platforms that these applications that are built on the Unify UX toolkit. Next one, Daniel. This is the early version of the prepare questionnaire that we're going through. And it's got a lot of capabilities in it, such as multi-language support. I think there's about 15 different languages that are supported in there. And if your language is right to left, the application adjusts itself to be able to do that, fill it in from right to left, different themes, different languages, and so forth. But as I said, what we're focused on now is how do we make this even more usable so people don't get frustrated with filling out these questionnaires and then moving forward. So our group in the UX working group is going to be focused on how to improve this and how others can utilize this technology moving forward. We've got a couple more applications that
That's the end of your time, Dave.
That's it.
That's it.
That's it. So the bottom line is take a look at getting involved with the UX working group. I think you're going to learn a lot as we go through it, and we're clearly going to be leveraging new and emerging technologies to best implement the solutions of the future.
Thanks, Dave.
Sure.
Your persistence and commitment is well appreciated by not only me, but a lot of people on this call. So keep hacking away there.
Keep hacking away. Thank you, Daniel, and hope I'll see you folks in the working group.
Yep. So we're going to just, we're at time. We're going to continue for a couple more minutes. For folks who can stay on, by all means, we're not going to jump off here. So if you got to go, but let me just I want to do two things, and I want to talk about the working groups and as well. One of the things we're doing that kind of undergirds a lot of this work is a training program that we've developed over the last 10 years. And the idea of that is once you connect all the dots and the boxes and the wires, what do you do with that information? How do you use it in a multi-domain, multi-sector, multi-program organization? And we put together a pretty extensive training course and a certification program that we're now launching with the National Association of Social Workers, initially in California. And we have our first cohort of this group going to be starting up in just a couple weeks here. So you've probably seen some of this in our newsletters. Fundamentally, I can go on about this, but I'll just say two words. One is to sustain change in an organization, people have to have a common vision, common values, and a common vocabulary, and some common tools and models. And ITCC is attempting to do that, both to build capabilities and also sustain that going forward. A lot of stuff on the Stewards website about it. If you're interested, call if you want to join, or if you have people you want to send to the training. We've got a couple more open positions for that. But I'm really excited about taking this information we've been doing and making it available now more broadly to the broad community. You've been to the website. If you haven't, there's all sorts. This is lots of materials on here that are specific to what we're talking about and we've been talking about. So you can go into great detail, more great detail of what we've got. And this is really, I think, the last slide. There's another slide here on resources. We're gonna post all this stuff. So a lot of these resources and the links again are on the site. But I want to just finish with this, which is we want your involvement. This has been a labor of love by a number of people. Obviously, all of you who've been participating in the NAA. I want to convey today that work is going forward despite the crazy times of the last year that we've survived. But we're trying to push the peanut ahead, and that requires resources in the form of people, time, brain power, money, sponsorship, those kinds of things as well. What's on this slide here are the work groups that we are working on at different levels and to different depths, depending on the subject matter experts involved and available time. But the Unify group meets every week on Wednesday afternoons and really kind of dives into this stuff. We're going to be starting up the privacy and consent utility service very quickly. And then these other pieces here are really important groups. Person matching, we'll be picking up on the ONC's work for this in particular, and other areas where the accelerator sites have done more work in this area. There's a governance site, there's a UX and UI that Dave showed a little bit now, ontologies and data models, user stories, and architecture. If you're not feeling like you can participate in one of the technical groups, as you know from the hub, there are a number of other affinity groups. There's social determinants, there's legal, there's other things like that. Curation, participation, support, it's what keeps the community going, and it will potentially accelerate the work we've got going here. So thank you for your attention. We'll post all this stuff on the site. We'll have the video of this available for those of you who want to binge watch it or subject your spouse to it over the weekend. It probably won't be up on the weekend. You have to plan it for next weekend. And for those who want to hang out for a little bit more, we don't need to close this down. If there's any questions, comments, thoughts, I'd love to hear from folks. Floor is open. And for those who have got to jump, go ahead. Thanks so much. Just stay in touch and send emails or join the group if you haven't. But comments and thoughts, welcome.
I was just going to complain. My spouse was really looking forward to seeing the tape of this weekend, Dan. So I'm not sure what we're going to do without it. One, I was just impressed with the 3 technical demonstrations, and thank you guys for doing that. One of the concerns I've had is, though, that doing simple referral, they're not simple, doing referrals is kind of copying medicine, the traditional way of doing medicine. If I'm a primary care provider, I analyze you, you've got this problem, I send you a specialist. If we got a closed loop system, I get a report that it's done, we're done. And we're moving out of that in healthcare, trying to adopt a much more longitudinal, holistic view of the family and the individual to kind of help them over time move from A to up towards thriving. And so the systems need to be that now expand beyond healthcare and treat healthcare as just one piece of that, and these other critical areas we really need to be thinking of them not as closed loop referral systems only, because that's a piece of it. But as Christine designs her system, she's looking at teams that are helping people succeed in life going forward. And that's what Inc. is moving towards. And so I hope the IT will be following that approach as well, rather than replicating the kind of, because the commercial products are just doing referrals. And I think we need to be thinking beyond that.
David, this is Greg Bloom. I think that's a great point. And I wonder if you have any language to offer from that experience about, like, if referrals aren't the thing, or at least aren't the main thing, and I agree, the concept of a referral seems to be one use case among potentially many. Do you have a different framework for thinking about what interoperability entails and what it enables beyond referrals?
Yes. If somebody with your lived experience is your point of contact, so somebody working for Christine talks and looks like you, and over a period of time gets to know you, and working with you as the member, not the patient, the member or the participant, and with the experts from these different social work and housing or food, comes up with the success plan for you, for your family, and then implements it over time. That will involve referrals, and you want those to be closed loop. Don't get me wrong, but it'll also involve kind of management of a plan. Now, the narrow version of that is a medical care plan, and I'm not talking about that because that's too narrow and it's too medicalized. But the same idea, and there's a team working there, on your behalf, with you and on your behalf, and that team, I would stress, is not just agency people. I mean, it's important to recognize that most of our success in life comes from our friends and our neighbors and our families. So so the team person that Christine's assigned to you may well have family members as parts of it, or a church, or it's not just the housing agency and the food agency, and so on. So it's that, and then these relationships, in order to really work, are going to have money attached to them. So instead of just having a success plan, that success plan is going to have money flowing with one of these. It won't just be a referral, it'll be a payment.
So I think what David said was so crucial. Greg, I see the same thing happening. To echo what David said, like you have one paradigm that's common is the care plan. You see these care management systems, multiple healthcare providers and human service providers. They're on a value-based care, and they have very specific clinical metrics they need to make. But like, as David said, it becomes too medicalized, and it ends up acting as like a separate system that the human service provider has to update in addition to their regular day-to-day case management system, right? Because there are no standards in the human services world, like to semantically define things, right? And the Gravity Project is very, very early, right, in this process from like a healthcare, fire, social risk perspective. But because there is kind of a lack of kind of customized case management systems that can meet both the human service needs of the human service providers and meet the kind of clinical care management needs of the healthcare providers. So I think that's where the gap is. I hope that is of use. Yeah.
Thanks, guys. Is Charlie, are you still on with us? I was going to.
Daniel, can I just add something to Matt's point?
Well,
I think I totally agree with both what David is saying and Matt saying, but there are some standards out there, Matt, that have been developed in the National Information Exchange model for human services for specific exchanges, particularly those that cross over from juvenile justice, family services. The family services domain and NEAM has started down this path, even though it's my opinion that Department of Health and Human Services hasn't really fleshed out the human services domain the way it should. It's a great start towards defining those kinds of standards you're talking about. And there at least semantic agreement on a lot of terminology that's been addressed as a starting point.
The guy who was dean of our medical school for 25 years is an expert on child abuse. And he was telling me, describing the world of social service agencies involved with child abuse and the medical groups as tectonic plates that are kind of moving slowly towards each other at the speed of tectonic plates. So this was extremely discouraging to hear. So I've decided to let somebody else solve that problem.
Oh, I want just to respond, or I wanted to invite Brian, his perspective, since he's the NEAM expert, on what NEAM does well, or where, yeah, essentially the role of NEAM in kind of advancing these human service standards.
Compared to Paul Wormley, who is bringing up this point, Matt, I am a piker. I am by no means the NEAM expert compared to him. However, I can say that that having spent a good deal of time talking with Tom Carlson, I was once the NEAM Health technical lead, and Tom was my equivalent colleague. as the human services, the NEAM human services domain technical lead. And we were each grumbling, I guess, is the most tactful way of putting it, about the fact that there just hadn't been the investment at a federal level or a state level in defining either NEAM health mappings to healthcare standards, nor for operational information, nor were there the operational standards being defined within the NEAM human services domain. Yes, there are within human services, there are IEPDs, schema definitions that had been created for human services, but they were largely oriented around reporting from the states to HHS on an annual basis, not the necessary IEPDs or method specifications for doing anything operational on a day-to-day basis, like handling a SNAP application or a rental assistance application or any of the 300 other some odd services, benefits, and programs for which there needs to be some kind of standardization to enable software vendors to build competitive and cost-effective interoperability solutions. So instead, what happens is every state has their own PDFs that they put out that have to be hand filled in either by social workers or by the individual, and then faxed over to the agency, whatever agency or CBO that's involved. And then, somebody has to re-enter the data. And as a consequence, you can imagine, yes, it's a tectonic process, but largely because it requires human beings to actually do a lot of grunt work to enable enrollment in any kind of service, benefit, or program. And that's something we need to fix. And if, I'm a huge fan of NEAM. I've been a NEAM architect since 2011. But if FIRE is making more progress through the Gravity Project in defining standards-based interventions for food insecurity, then NEAM is, and the NEAM human services domain is at the moment moribund. Well, you got to go where the money is. You got to go where the progress is being made.
Yeah, but Brian, you're underrating what's been done in human services. There are operational exchanges that have been built. NICE, for example, is the operational exchange of information between states on the transfer of custody of juveniles from state to state. Mm-hmm. That's a NEAM-based operational exchange that's in place. There are family services exchanges between social services and juvenile justice that are in place. And some counties in the country have implemented those exchanges that are NEAM conformant. There's not enough of them. I agree with that. And what I said earlier is that I really don't believe HHS has been the steward that it ought to be. But the fact is that those a set of semantic definitions, semantically harmonized definitions across domains has been developed, and many of the data elements that are essential, as you well know, Brian, for the kind of exchanges, data about people and events and locations and organizations, those data elements and both their semantics and the syntax is defined in the NEAM model, and they form a basis for it. And as you also know, Brian, you're going to help me solve this problem of motivation by the work on the Tiger team that you volunteered to help me with.
But I'm also trying to provide some perspective that there are a bunch of folks, not just me, but who have been beating our heads against this wall for more years even than I have been trying to do it. And so it may be a race,
Well, we'll talk about whose head is more bloody, because I've been at it probably longer than you have,
A
but
lot longer than I have. So
I'm telling you
well,
that
you have a harder head than I do.
I know I'm an eternal optimist, but I think there is some optimism because of the fact that there are people who are managing NEAM now that first of all have money and have access to money and influence, as
Good.
DOD has taken this over. And the proliferation of NEAM and the international acceptance of it, even as Canada has just jumped out ahead of the US in implementing NEAM, is making it more popular. So there's hope for it. There's definitely a place for fire. We've talked about this, and we've talked in the Project Unify discussions and elsewhere about how important it is to have a connection between fire and NEAM, and to be able to deal with the worlds that use those different standards. Fire is not popular or used in any way in the whole justice field. It's not used or popular in the education field. So,
Yeah.
we have to have domain agnostic ways to exchange information. And I like what Open City Labs is doing in that regard. It just we need to recognize, as you guys have in building Project Unify, that each domain has its own predilections for some kind of standard language. And we've got to, I'm really getting more and more persuaded to copy President Reagan's exhortation to Mr. Gorbachev, tear down these walls.
Absolutely, Paul. And I definitely didn't want to be clear that I wasn't dismissing the kind of domain specific data exchanges and data standards that you mentioned, like NEAM. There's plenty of standards out there for data exchange. The problem is getting agreement across domains to align to a single standard, right? And I think that's part of what the National Action Agenda has been about, is about how do we advance this cross-domain, cross-sector work to advance common standards. So I think that's really critical. I'll also add that one-stop shops are very similar conceptually, right? It's not a new idea to have a one-stop shop, right? HUD has integrated eligibility, right? That's a one-stop shop of housing programs. Similarly for programs for aging, right? So the problem is that aggregating that data across agencies is more nuanced as an idea. So I think both of these, finding what Brian likes to see, this is Brian's phrase, intersections of interoperability, right? Between,
I hate that phrase. We have to find a better one. Even though
I like that. Intersections of interoperability across domains, and how do we choose those where we can find motivated partners on both sides that want to cooperate, right?
Keep in mind, that's the problem. Is it's not a technical problem. We got really bright people like you guys who can solve the technical problems. The problem is with Christine mentioned right at the beginning. She was told, "Hey, go get the data for all of these people that you're trying to help," and the people who own the data said, "You're trying to help our people? Go away. These are our people, or at least the food for them is our people, and the housing is." So. I mean, it goes back to the federal government's role here. The federal government tends to fund silos and show me the interoperability program. The fact that CDC put $250 million behind backbone exchange networks recently in grants is nice, but that's bupkis compared to the amount of money being spent on infrastructure. I mean, we're about to have $600 billion with a B spent on roads and bridges, and a whole lot of money spent on IT infrastructure too. What we're talking about here is infrastructure. It's the most important kind of infrastructure, and I don't think they've yet looked at it. If you go back to 2009, what did they do? They poured money into my business to bribe every doctor and hospital to have an electronic health record. and they put very small amounts of money into making those interoperable, and look
Yeah.
what they got. So maybe, and these are the same people just promoted to higher positions. So maybe, Daniel, you could be telling them.
That's the plan. In fact, the actually, what, in addition to the stuff I've showed you here, we've actually got a lot of additional sort of outreach efforts going on that are reaching into the various segments of the federal um, 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 bureaucracy. And I'm heartened to hear a little bit from some of the work involved with HIMSS and the SDOH group that they brought together, a great group of people. This conversation came up the other day. I said, well, what's happening? Is there federal coordinating councils going on? And the answer was, yeah. I mean, they named a lot. I don't know if to what degree it's happening, but it was like, yeah, there was efforts to bring in many agencies that I would think would be a great starting point for that. Who's sort of orchestrating that? I don't know where that authority lies at this point in time, but there's movement there, which I think is maybe good, because to your point, David, and we could blow through a lot of money and end up, with our same silos that are not working with each other.
I don't know about a working group, because the checks are on the way out to the states right now to fight COVID.
Yeah, but right, but getting the state, maybe the folks who are involved with states could help, sort of figure this out, because state dollars have a hard time sort of funding innovation or funding anything other than what they've been allocated for. And while there's a tsunami of money coming, I don't know how much of it actually has interoperability attached to it. Although Medicaid did, in their Medicaid letter, that they put out just at the beginning of the year, reinforced 90-10 for interoperability. So it's there, but they getting the attention of the state folks, and Christine can talk to this as well, I'm sure, as others. Their plates are full, and they're crazed, and they're trying to solve COVID, and what's this interoperability thing? How do you spell it? Right. So it's as our mentor Rick Friedman, formerly of State Systems and Medicaid, for those who remember him, it's a heroic journey, but it's a journey.
I think there's more optimistic possibilities of getting the states to understand this than there's the federal government. Actually, when you get down to it, the state CIOs have a whole plethora of problems to solve that are across domains. They can't be satisfied to deal with a single domain, and they're seeing more and more the need to come up with standards and to address these things. And I think we have to, all of us that are on this call, have to help light the fire with people to understand that interoperability is at the basis of all the collaboration that people talk about. It's exactly what David is saying, that you have to build a community response and have the technology support that community, not have technology be involved in the proliferation of more silos.
Amen, Brother Paul.
All right, with that, I've got to go to another call. So
okay, everybody, thanks. Have a great weekend. We look forward to seeing you. Email, fax, send the pigeon or whatever. See you online.
Terrific call. Thank you.
Great.
Thanks,
Thanks, everybody.
Thanks, everybody.
Take care, all.
Bye. Okay, recording is